Hello, everyone. We're going to go ahead and get started. I'd like to introduce our speaker. Dr. John Blenko is a graduate of Haverford College and University of Pittsburgh School of Medicine, where he completed a residency and fellowship in anesthesiology at the University of Pittsburgh. He is one of our initial members of Clarity's PSO Healthcare Advisory Council and continues in that capacity today. He recently retired after 33 years of practice in anesthesiology, during which he worked at the R. Adams Cowley Shock Trauma Center at the University of Maryland. He also has a particular interest in moderate sedation and cardiopulmonary resuscitation and has lectured on both of these topics nationally. And with that, I'll turn it over to John.
Well, good morning, everyone. I guess really it's afternoon for those of us in the East Coast. Good afternoon. As Heather said, I'm John Blenko, and I've been a member of Clarity PSO's Healthcare Advisory Council since 2009. I've recently retired, and as Heather said, I've got an interest in moderate sedation, CPR, resident education. Well, it's still summer, I guess for another week or so. I can never remember whether it's the 20th or the 21st that we switch. But today I'd like to discuss 4 topics that I'm going to call low-lying summer fruit. These are, I think, relatively easy for you to do, and they yield some pretty great gains in terms of patient safety. And they also yield gains in terms of your staff satisfaction, and your staff are really your biggest resource, and the more you can make them happy at the end of the day and less stressed, the more that's going to pay off for your institution. We're going to have time at the end for questions and answers and some discussion. But what I'd really like to do is if one of you has done something along the lines of one of these 4 topics, I'd sort of like to put you at the head of the line and have you share that with us so that we can take what you've done back to our own institutions and hopefully won't have to reinvent the wheel. We're first going to look at the topic of moderate sedation. Moderate sedation is something that all anesthesia providers learn in our training. We learn the drugs, we learn their kinetics, how to dose them, we learn airway management, we learn monitoring techniques, and it's something that we've done hundreds of times during training and then that we do on a daily basis in our practice. We make it look really easy. It's like the surgeon doing a lap chole or the ER physician putting in a chest tube, and we make it look easy simply because we do it all day, every day. It's really one of the tenets of our practice. So why are we talking about moderate sedation today? Well, the public is demanding moderate sedation for more and more procedures. I think the first thing that would come to mind for all of us is colonoscopies, endoscopies, breast biopsies, and so forth and so on. And I've even had an increase in physician demand in the hospital for moderate sedation for things like chest tubes, central lines, and so forth and so on. Now, there's this graph up here, and you can argue with the slopes of the lines. Maybe say, they should be steeper or flatter, but the take-home message here is that we simply don't have enough anesthesia providers to provide the level of moderate sedation that's requested today. And so by necessity, we have turned over a procedure that we do thousands of times and have studied very, very well, involving very, very potent drugs. I'm reminded of Michael Jackson and critical monitoring to non-anesthesiologists. So moderate sedation by non-anesthesia providers may be a little bit riskier, may involve a little bit higher level of concern simply because they don't have the experience in it that we do. This was a hospital-based survey, multiple hospitals. They were self-reporting, but they were asked to talk about some of their moderate sedation events. And you'll see, based on this survey, that 1/3 of them occurred in the GI lab, and yet of the patients that were symptomatic, over half of them were in the GI lab. So sort of the symptomatic to location ratio was higher in the GI lab. than other areas. You'll also note that 40% of the patients in this survey required administration of a reversal agent. Now, this is a drug like naloxone or flumazenil to reverse narcotics or benzodiazepines. Now, in the operating room, we would just love at the end of an operation to snap our fingers and have that anesthetic disappear like that. We're unable to do that. We do have shorter agents all the time, but we still have some residual agents left at the end of the anesthetic. But we do sometimes use reversal agents in the operating room. So I'm willing to take this 40% and drop it back by 3, 4, 5% to 35%, but that's still a pretty high number of patients requiring reversal at the end of a procedure, and it is something that we might want to look at. Now, there should be one standard of care for moderate sedation throughout your institution. The Joint Commission mandates that patients receiving similar services throughout the institution get the same standard of care, and that's in all phases of care, pre, intra, and post-procedure, post-operative. So you should be providing the same level of care in your cath lab, in your GI lab, in your urology suite that you're providing in the operating room. I would like to spend a minute and talk about Untitled CO2 monitoring. This is the sampling of patients' exhaled air for carbon dioxide. If we don't see any carbon dioxide, we know that patient's not breathing. The number for the Untitled CO2 gives us an idea of how deeply that patient's breathing, and the monitor also calculates the respiratory rate for us. Well, in 2010, the American Society of Anesthesiologists revised their standards for basic monitoring of patients, and during that time they said that the adequacy of ventilation shall be monitored for patients receiving moderate and deep sedation. Now, CMS does not regard moderate sedation as an anesthetic, but they do say that anesthesia services throughout a facility should be provided under one set of standards and under one director. And so if your moderate sedation director is an anesthesiologist and they're following the ASA guidelines in the operating room, it makes sense that they will be pushing those out throughout the entire facility, even though, as I say, CMS does not mandate it. This was the latest information that I was able to find from CMS. They sometimes sneak stuff in under the radar. So if any of you are aware of a more recent ruling from them, if you would bring that up in the discussion, I'd appreciate it. Now, sedation continues across a continuum. Anxiolysis is the administration of PO drugs, say Valium or Ativan, for someone having a procedure like an MRI. And moderate sedation standards really don't apply in this case unless that patient becomes so sedate from the oral drug that we're forced to monitor them and moderate sedation guidelines do kick in. The drugs that we give for moderate sedation are given IV, and there's a quick change in blood level when we give it, and there's a potential for a very rapid change in the patient's level of consciousness. And staff should be able to rescue patient from one level of sedation deeper than they plan to administer. So if you're providing moderate sedation, as I say, it's very easy to pop that patient into a level of deep sedation, and so your staff should be able to rescue them from that deeper level. And so I guess the first question that I would ask today is, what level of sedation are your patients getting? During my 25 years in the Cowley Trauma Center, I worked with literally thousands of residents, not only from the United States, but really from around the world. Emergency medicine, internal medicine, anesthesiology, surgery, pulmonary and critical care fellows. And I always talked to them about moderate sedation. And I said, are your patients responsive? And I got replies like, are you kidding? They're asleep, they're out, they're unconscious. And so your patients who are signing consent for moderate sedation and your providers who are providing moderate sedation, are those patients and providers really working in the moderate sedation level, or are they working in the deep sedation level? If they're routinely unconscious, we need to think about credentialing those providers for deep sedation, which involves more training, a little higher skill level, and making those patients aware that they're getting more than just moderate sedation. Let's talk about staff credentialing for a minute. When you credential your providers for moderate sedation, do they have to perform a certain number of procedures under the supervision of someone who's already credentialed in moderate sedation? Do they have to demonstrate that they know the drug doses, that they know the drug kinetics, that you don't give a second level of a drug until the first level has had time to reach a peak level of effect so that you don't get staircasing? Have they shown that they understand monitoring and some of the other risks involved? The biggest risk of moderate sedation is respiratory arrest. And so are your providers required to demonstrate some basic airway skills, because they'll be responsible for that patient until the code team gets there. Now, I think ACLS is probably overkill for someone getting credentialed in moderate sedation. Your facility may choose to do that, but it's probably a little bit more than you need. CPR training now is video-based, and it does discuss use of a bag valve mask, but the video kind of keeps rolling, and if someone's having trouble demonstrating bag mask skills or getting a tight seal, the course, as much as I'd like to say it does, really doesn't give the instructors the opportunity to just stop it and let someone give them the individual hands-on attention that they need. So you might want to consider having sort of a separate airway assessment station or skill station for your providers. Have them demonstrate use of a bag mask, insertion of oral and nasal airways, suctioning of the pharynx. You might even choose to take them into the operating room to do that, but that's probably a scheduling nightmare. When your staff are re-credentialed, are they required to, again, demonstrate those basic airway skills? Do they have to re-demonstrate their mastery of the didactic material, drugs, dosing, monitoring, airway assessment, and so forth? And do you look at their any moderate sedation events that they've had in the last 2 years, which may give you a clue or a key, does this person maybe need some more work? I'd like to again kind of talk about reversal agents for a minute. As I said, even some anesthesia patients get them, but you may want to look at those moderate sedation cases out on your procedure areas and perhaps use administration of reversal agents as a marker for oversedation or adverse events. And with computerized CPMOE and computerized pharmacy records, it's very easy to tell who got reversal agents. And as long as we're talking about them, I'd like to suggest that they actually be in the procedure room where the procedure is being done, and not just in the Omnicell out in the procedure suite. And the reason for that is, suppose you have, for example, a pulmonary lab, you have 2 procedure areas, and procedure area 1 needs to get some reversal agents. They run out to the Omnicell, and whoops, procedure area B has already taken them out of the Omnicell. If you have a set of them in each procedure room itself, you know that they're there. You don't have to worry about have they been lost. You want to look at your process. Does your sedation process really work as your policy is written? And I think probably there are a lot of things here, you can read them. I think the most important thing is that the LIP ordering that moderate sedation needs to do their own airway exam immediately prior to the procedure. You don't want them just saying, oh, 2 weeks ago somebody looked at this airway and said it's a Mallampati 1, because that person may have made a mistake. One person's Mallampati 1 is somebody else's Mallampati 2. Mallampati is an airway assessment exam that we do. The airway may have changed. It's just very, very critical that that LIP who's going to be ordering sedation for that patient knows what their airway looks like. And then you also want to look at your high-risk events or deaths, and you should look at 100% of these. I have put this list together pretty quickly, but I think you can all take a look, maybe add some things to this, but you do want to look at your high-risk events 100% of the time. And so just some thoughts to ponder as we leave this topic. Do you have the same standard of care throughout your facility for moderate sedation? Is deep sedation being practiced under the guise of moderate sedation? Does staff have to demonstrate some basic airway skills for both credentialing and recredentialing? Do you look at your administration of reversal drugs, and are you QAing your moderate sedation procedures? I'd like to move on now to the second topic, emergency manuals and protocols. Now, you may not see Rodin in your operating room, but hopefully you are seeing now or will see very quickly the use of emergency manuals and protocols. Well, does adherence to these protocols really make a difference? We all remember our first ACLS course, and we got a little pocket card and we carried that with us religiously so that if we had a patient get into trouble, we could get it right. I have to say that many of the studies that have been done on adherence to protocols and the protocols themselves have been done with ACLS as the model, just because it's been around for so long. This was a study by McAvoy. It was retrospective. He looked at 149 patients that had an in-hospital cardiac arrest, and half of them had ROSC, return of spontaneous circulation. They were alive at the end of the code, and the other half did not. And they went through each paper resuscitation record, and they determined a percent correct score, and that was the number of correct actions that the team leader performed over the number of expected correct actions. Because codes were differing lengths and had differing complexity, you couldn't just look at the number of correct actions. You had to work it out as a ratio. And what McAvoy and his group found was that the higher the percent correct score, the greater the chance of that patient having return of spontaneous circulation. They also looked at steps that should have been done and weren't, and steps that should not have been done and were, and both of those negatively correlated with return of circulation. Interestingly to me, and I've been teaching ACLS and BLS since 1973, this was just fascinating. They found that greater than one error in management, and we all know how complex it is to run a code, they found greater than one error in management roughly halved the rate of return of spontaneous circulation, which I thought was just amazing. So apparently adherence to these protocols really does matter. But how do we adhere to those protocols? This was another study by McAvoy. He used medical students. They were managing a simulated cardiac arrest, and each medical student managed two different arrest scenarios. One they managed from memory, and one they managed using a decision support tool. The decision support tool was an iPhone app, and the medical student would open it up, and it would say, is there a pulse or no pulse? This was a cardiac arrest, so of course they would check no pulse. And then there were pictures of the EKG rhythms, VFib, asystole, and so forth, and they would click on the appropriate rhythm. And the decision support tool would give them a series of management steps. You know, place a backboard under the patient, start CPR, that sort of thing. And you couldn't do one management step until you had done the ones before it correctly. For example, you couldn't give an antiarrhythmic until you'd given a vasopressor. And when you checked off the steps as they were done, it time-stamped them. It uploaded them to a computer so that they could be used for research or inclusion into a patient's chart. And what McAvoy found was that the students using the decision support tool had a much higher correct step score than the students working from memory alone. They had fewer errors of commission. He did note that the time to first defibrillation was similar when the student was working from memory versus using the decision support tool. The decision support tool was no quicker in getting that defibrillation out, but neither was it any slower. And in 2011, Lowe did a study. This was out of Great Britain. Again, simulated cardiac arrest, and I believe these physicians were residents. They had their own app. It was called the iResus app. And whereas in the United States, when you take an ACLS course, you either pass or fail the final exam, in Europe, you actually get a numerical score at the end of your resuscitation simulation. It's called the cardiac arrest simulation test. You actually get a numerical score, and what Lowe found was that people that used the iPhone app actually had a higher score than those that worked from memory. Let's look a little bit deeper at simulation, at cognitive aids, and at team training. This was a review article published by Marshall in 2013. He looked at many, many studies looking at these areas. Now, as we know, guidelines and protocols are encyclopedic. They list all the evidence for us. They'll list pro studies, con studies, day of the week, everything that's out there. And then from those guidelines and protocols, cognitive aids are made. The cognitive aids are really the essence of the guidelines and the protocols distilled down to something you can throw in your pocket, be it a plastic card or an iPhone, something like that. And the cognitive aids are useful when the stress levels are very high, high intensity stuff. People can get tunnel vision. They can miss things, and the cognitive aids are meant to help pull them from that, help them avoid doing things that they should do, and help them avoid doing things they shouldn't do and do things that they should do. And Marshall made the comment that the cognitive aids really need to be practiced with ahead of time. I can't imagine running into a room and somebody's in cardiac arrest and someone just throws me the ACLS card and says, "Go at it, Tiger." This is something you really need to look at that cognitive aid ahead of time so that you kind of know what's there. It's like reading the manual in your car, that 400-page thing they throw in there now. At least you know what's in there, skim through it, so when that light comes on, I know where to look in the manual to find it. So you should practice with your cognitive aid ahead of time so that when the time comes, you're not looking at it for the first time. And of the 13 studies that Marshall looked at that looked at cognitive aids, 10 of them found that the use of a cognitive aid was helpful. 3 of them found that it was not. There were 4 studies looking at the effect of cognitive aid on team performance, and it was a mixed bag here. One of the studies found that it did improve decision-making, and one of the studies found that it improved team coordination. 2 of the studies actually said that use of a cognitive aid decreased team communication, and they felt the reason for that was that the person using the cognitive aid was focused on the cognitive aid and muttering to themselves as opposed to talking to the rest of the team out loud. And in summary, Marshall also said that, again, that the cognitive aids are very, very important. They need to be designed from the guidelines. Human factors on cognitive aids are very, very important. Things like which font did you use, what color are various things, what's the shape of your arrows, what's the shape of your decision boxes, how are things laid out on that card. Human factors is a study that looks at all of that and tries to minimize the risk for human error. So if you have access to anyone in human factors in your facility, in your university, can borrow a human factors person from someplace else, and you're trying to design your own cognitive aids or manuals, I think that would be very, very helpful. Marshall again reiterates that you need to test your cognitive aids in the sim lab and make sure that it really works. Of all the studies that he looked at, there was only one that designed a cognitive aid, took it in the sim lab, went back and rewrote it, so to speak, and tested it again. Another very interesting topic that's really just kind of coming to the forefront things is how we convey that information that's found in the cognitive aid. In 2012, Burden published a study. This involved anesthesia and OB residents. They went through 31 simulations, and they were being tested on either obstetric cardiac arrest or malignant hyperthermia. And the cognitive aid for the simulation that they were being tested on was attached to the crash cart. And so when this resident started to run the simulation, they of course called for help, and a team came in from the sim lab. They were all Confederates, and they knew what to say and what not to say and so forth and so on. One of the people that came in as part of that simulation response team was a medical student, and their job was to be a reader if the resident was having trouble managing the simulation. And Burden actually published the script that these readers use, and I think it's fascinating. If the resident was still having trouble after 5 minutes, the reader would look at the cognitive aid and say, what is this paper? Will it help you? And if after 10 minutes the resident was still having trouble, the reader would say, this paper looks like it might help you. Would you like to use it? And if the resident was still having trouble after 15 minutes, the reader would say, I think this paper has useful information. I'm going to read it out loud. And during the debrief from these, for these 31 residents, they indicated that trying to use the cognitive aid and manage the resuscitation by itself was very, very stressful, and they all commented on how useful it was to have a reader. One problem that I have with this paper was that it was a longitudinal study involving the same residents over a 3-year period, and you would think that as they got more mature in their residency that they would have more experience in team training, management, and so forth and so on. And she didn't really discuss that in the paper, but I thought it was a very good paper. Another paper was done by McAvoy, again, anesthesia residents managing local anesthetic toxicity. And here the residents either ran the scenario from memory alone, or they had a reader who used a decision support tool. And what McAvoy found was that the critical management steps were managed 0% of the time by the residents working from memory, and 94% of the time when they had a reader using a decision support tool. Well, you could say, hey, this is a double whammy. It's memory versus reader and decision support tool. Well, McAvoy had already done a pilot study where residents managed the local anesthetic toxicity using a decision support tool but no reader, and he found that the result was no better than if they were running it from memory alone. Residents either looked at the patient, the mannequin, and forgot about the decision support tool, or they stared at the decision support tool and didn't take care of the patient. So he put the reader and decision support tool together and found that that package was much better than working from memory alone. Well, who should be the reader? Many of the protocols ask you to do something and then make a decision. For example, give the patient a fluid bolus, and then the next box says, is the patient hemodynamically stable? Well, McAvoy says that you really need your anesthesia providers who are able to make that assessment step free from being the reader. Because if they're the reader, they're tending to focus just on that cognitive aid, that electronic device, and they're not really able to assess the patient. So use someone who's got some knowledge of the area. The OR knows some of the clinical routines, knows where equipment is, that sort of thing. Use an anesthesia technician or a perioperative nurse, but keep your anesthesia providers free so they can actually make those judgment calls. And again, practice, practice, practice with your cognitive aids and full team simulations. So I guess the take-home message for this section of the talk is that rare things happen. Well, rarely. Humans are fallible. We all make mistakes. We don't mean to, but we do. Malignant hyperthermia, obstetric cardiac arrest, air embolus. Many anesthesia providers will go through their entire career and never see any of these. But they could see all 3 of them this afternoon in your institution. So checklists are there to help you in times of stress. They're particularly useful if created by a multidisciplinary team, and I'll talk about that a little bit later. And again, they need to be practiced. When Flight 1549 had the bird strike. The first officer was flying the plane at that time, and the first words out of Sully Sullenberger's mouth were, "I have the command," and the second words were, "Read me the," and I think it was just called the Start Engine Protocol. He knew that when the chips were down, that he didn't want to rely on his own memory. He immediately pulled out protocols that had been practiced, that had been designed, by many, many people in times of low stress, so that everybody had a chance to contribute, that had been tested in the flight simulators that were known to work. So he didn't try to put anything to chance. He just went ahead and followed the routine. Have all of your stakeholders been involved? And by that, I mean, suppose you're working up your malignant hyperthermia protocol and you're putting in there, get ice. Well, you get ice from the PACU. Well, if you have a PACU nurse in there, she might say, remember, on Friday, Dr. Jones does 17 arthroscopies, and by 2 o'clock in the afternoon, our ice bin's pretty empty. So she would be able to make that missing link that, hey, we may have to have a backup location to get ice, and where is that going to be? And so the more people that you have involved making these protocols, I think the more complete your outcome is going to be. Who's your reader? Do you use a reader? And have you practiced complete drills? Next thing we'll move on to our third topic is patient handoffs. Well, what is a patient handoff? It's a break. It may be a 15-minute coffee break. It may be end of a shift and a pickup by someone else. It's a goodbye if that patient's going from one unit to another unit. And it's a new set of eyes on that patient, which is often a very good thing. A handoff is two-way communication. One person lecturing to a second person is not a handoff, it's a lecture. You need time for that second person to assimilate the information and ask questions back to the first one. We know that the vast majority of events in medicine are due to communication failure, and if you have a bad handoff, you're often setting the stage for a problem further down the line. Handoffs are not well studied, but everybody agrees that we need them, though. Are our providers right now happy with the handoffs as they are? This was a study out of Wayne State University in Detroit, and that'll be important in a minute. It was sent to all residents and faculty members in all the anesthesia programs across the country, about 4,500 people. It was also sent to a sampling of about 300 nurse anesthetists in the metropolitan Detroit area. Now, the response rate for this survey was only 5%, but 25% of the respondents were those nurse anesthetists in the Detroit area, so I guess they felt that they had to support the home team. But of the people that responded to this survey, only a little over half said that they had a handoff protocol in place at their institution, and only 11% of them thought that it included everything that needed to be there. 85% of them said that they had received a poor handoff from someone else, and they mentioned some things that were rarely included. We all talk about the patient's medications in the operating room, but people said, well, we really had no idea what they were on when they came into the hospital. What were plans for post-op pain? Many times they didn't know that that patient had antibodies on their type and screen. So many, many things that probably should be mentioned that really aren't. Why are our handoffs so suboptimal? We've got more information to report. Patient acuity is higher and higher. The lesser acuity patients tend to get done in surgery centers or private doctor's offices, office-based surgery. The number of comorbidities is increasing. We have more handovers to do. There's production pressure, either actual or because of our job stresses perceived, but we feel that we have less time to do that handover in. As you know, resident duty hours have decreased in an effort to make their training more humanistic, and several medical centers have noted that the resident handoffs have increased by almost 50% because of the decrease in resident duty hours, whereas a resident used to work 24 hours or 30 hours or 36 hours and sign off to one resident. Now in that 36-hour time frame, you may have 3 different handoffs. And I'm willing to bet that these handoffs are sort of like playing the game post office, that you get a complete handoff the first time, miss a few points the second time, and by the time you get to the 5th or 6th one, it may be nothing more than a problem list, and here's what to watch out for tonight. Very few U.S. medical schools teach how to do a handoff, only 8%, and I guess the other 92% then are on-the-job training. So what do we know? As we said, handoffs are poorly studied. I believe that the electronic medical records have really led to a decrease in handoff quality. There's just so much information in there. It's like all these slots in a post office, and you just want to get them all filled with facts and figures. I reviewed a chart about 5 or 6 years ago from a patient who was in an ICU, and this ICU retaped the endotracheal tube every 2 hours and moved it from one side of the mouth to the other. You may or may not agree with that practice, but each time it was done, it led to 2 pages in the electronic medical record. Who did the untaping? Who did the retaping? Who held the tube? What was the distance in the mouth? What was the lot number on the adhesive tape? They didn't ask that, but it was almost that bad. And I think humans have this need to just spit out all these facts, and I think that with all of these facts in front of us, it's more and more difficult to connect all the dots. So I think that the electronic record may actually be hurting us. The receiver is expecting certain information, and if they don't get it, they're frustrated. And if you have a standardized handover protocol, that helps. So how can we make our handover safer? You want to have one format, a standardized list of statements and facts so that everyone knows what to expect. You may want to have one set for the PACU and another set for the ICU. They're sort of 2 separate patient classes. One is sort of a quick in and out. The other is someone who's sicker, has a lot more information to report, and is going to probably be in that ICU for several days. You need to make sure that patient safety comes first, so make sure that all the monitors are connected, that the pulse ox is good, that you've got oxygen on if you need to. Make sure that patient's stable before you start the handover. I've seen problems where people want to come in, throw out their information and leave, and that's very often the surgical resident. And I think the best way to handle that is just come down from on high and have the CMO and the department chair say, you will make sure the patient's stable, and then you'll take your turn. You also need to keep that entire team there the entire time, because somebody may give their portion of the handoff, and then 5 minutes later you realize, oh, we've got to go back and ask them one question, but wait, they've left. So the entire team needs to be there the whole time. It should be a sterile cockpit. You don't want to be discussing extraneous things. Everything needs to be focused on that patient. And if you can train your team in team skills, active listening, using something like team steps or so forth, I think that's very, very helpful. So in summary, do you have standardized patient handoffs? As I say, you may want to use 2 different ones, PACU and ICU. And do you use team training? Our last topic for today is extubation of the airway. I'll let you start to read this. This is a middle-aged gentleman, obese, multiple medical problems, hypertension, diabetes, coronary disease. Came in for debridement of a perineal abscess. It was a long surgery, 4 hours. In our location, this was not necessarily long, but 4 hours. He got blood products. By the end of the case, he was on pressors, but hey, his temp was okay, and at the end of the procedure, he opened his eyes to command. His SAT was 100. He was taken to the ICU with an oxygen mask in place. When he got to the PACU, he was hypoxemic. He was apneic. The anesthesia providers were unable to ventilate or intubate him, and a request went out for a surgical airway. The patient had a hypoxic arrest and died. Something like this is devastating. Certainly to the patient, they're dead, the patient's family, the staff involved. I had a event in 2001 that I'm not going to go into, but I can tell you that I don't think there was a single day, and I'm not being facetious, I don't think there was a single day that I walked into that operating room that I didn't try and Monday morning quarterback myself. What should I have done differently? What could I have done? Beat myself up. To this day, I still think about that event. So if you can avoid things like this, it can really help your staff with long-term satisfaction and job performance. Now, this was a hypothetical case, although it was fairly similar to some of the ones that we saw every day in the trauma center, but we see patients with elements, certain elements of this case all the time. Well, what do the studies tell us? We know that airway events are common and they're serious. In a 1990 study looking at adverse events, airway events were 34%, 1/3 of all the events in the registry. This involves looking at malpractice cases that have been closed, and after damages have been awarded or not, a panel goes in and looks at each individual case to decide was care appropriate and so forth and so on. It is a little bit difficult to use these cases because we're looking at the numerator. We don't know what the denominator is. You could have a very difficult airway or a bad airway and yet manage it satisfactorily. So even though the bad airway is out there, we don't know about it. Where did these difficult airways occur? Well, 87% of them were in the perioperative area, and they're using that as a tag for everything from pre-op holding to maybe a pre-op block area to the operating room itself to PACU, but basically the one floor contiguous areas where your people practice 90% of the time. But 1/8 of them were outside the operating room, the ICUs, the procedure areas, the emergency room, things like that. And while the outcome in the perioperative area was bad, outside the operating room, it was absolutely devastating. 87% of the patients were dead, and 13% of them had brain damage. Well, let's look at extubation for a minute. It is certainly less well studied than intubation. If you go to any of the anesthesia textbooks and go to the difficult intubation section, you're just going to find hundreds of words, and they just pop up all the time. Mallampati score, thyromental distance, ramp the patient up, awake FOI, video laryngoscope. I could go on and on and on, but there's just so much written about intubation. I'm being a little facetious, but when you go to the extubation section, it's almost like extubation, and it just says take it out. Difficult airway intubation is still going to be there at the end of the case, and it may even be worse. You may have swelling around the airway, which is going to make you more prone to spasm. You may have secretions around the endotracheal tube that's going to make you more prone to laryngospasm. And extubation may be a more dangerous time than intubation. We're under that production pressure I've talked about. Extubation may not be decided objectively. You may even have a different anesthesia provider at the head of the table that wasn't there for the intubation. Well, let's look at checklists again. Humans are prone to errors just because of the fact that we're humans. We are not that seatbelt sensor that's going to beep incessantly until the seatbelt is clicked. We can and we do make mistakes. We don't mean to, but it happens. I Googled have checklists increased safety in nuclear power plants, and there were 397,000 results. And then I Googled have checklists increased safety in aviation, and there were 1,030,000 results. Now, I'm not going to have time to cover all of these papers today, but I think the take-home lesson is that checklists have increased safety and decreased accidents. Even in medicine, I Googled have checklists increased safety in medicine, and unfortunately the first thing that came up at the top of the Google page were ads for malpractice attorneys. So I guess this is something our patients are looking at. But there's evidence for checklists even in medicine too. We all know the Pronovost study where he looked at central line insertion checklists and decreased patient morbidity and mortality. Atul Gawande in 2008 invented a surgical checklist that was used at 8 hospitals of the Harvard system. And when those results were compiled, it was found that after the introduction of the checklist, there was a 36% decrease in major complications and a 47% decrease in deaths. So even in medicine, checklists increase safety and productivity and decrease costs. Well, would an extubation checklist help? As I said, I worked at the Cowley Trauma Center in Baltimore, Maryland. We were the primary trauma center, adult trauma center for the entire state. We also took patients from surrounding states, and we also received patients from the military that they were unable to take care of. And we had about 8,000 admissions every year of some of the sickest people I've ever seen, and we did about 8,000 operative procedures a year. And failed extubations were our biggest QA indicator in anesthesiology. We had about 30 of them a year. And so 2 of my colleagues, Bill Howey and Rick Dutton, came up with an evidence-based checklist for extubation. And in addition to patient meeting the normal physiologic criteria such as SAT and respiratory rate and so forth, anesthesia providers were asked to answer the following 8 questions. Was the patient awake, followed commands, were they agitated, were they cooperative? You can read them here. And after that evidence-based checklist was introduced, we found that the documentation of readiness for extubation, as documented by the anesthesia providers, went from 54% to 92%. We also found that our extubation failures decreased by 52%. Well, let's also talk about extubation outside the operating room. The staff that are there for that extubation, such as in the ICU, were probably not there for the intubation. In fact, I know they weren't. And even if you send anesthesia providers up to that ICU to help with the extubation, they may not have been there for the intubation either. The electronic medical record is not always checked. Very often the banner at the top of the patient's name talks about their code status, but it doesn't talk about difficult airway status. In the paper days, it was really, really easy. You just ran to the paper chart, opened it up to the operative section, looked at the anesthetic record and said, oh, problem or no problem, and went back to the patient, or maybe somebody taped a 3x5 card to the front of the chart that said bad airway or read anesthesia notes, something like that. But I think it was easier to find these things in the paper chart days. They're there now in the electronic medical record, but it can be difficult to find them. This was a rather low-tech solution that was designed by the University of Virginia Medical Center. Each of their anesthetizing locations has a sheet of these stickers, and if they have a difficult intubation, they attach this tape to the endotracheal tube so that when people are getting ready to extubate, they're aware of it. We also have patient markers. We're all familiar with the difficult airway band that patients wear. The band is only as good as its application. If nobody knows where it is, or production pressures, or, oh, they'll put that on the PACU, we're not going to do it here in the OR. If you don't see it, you miss that link in the information chain. Each of your anesthetizing locations should have a couple of these bands so they can be slapped on right away. Of course, we've got to notify the patient through an airway letter and also make them aware of the medical alert difficult airway registry. Sometimes patients take things into their own hands, or in this case, arms. On the right, this was an actual patient that we had. She came in, girl in her 20s, after an auto accident, and as she rolled through the door, she said, I'm a very difficult airway, and trust me, she was. But her uncle was a paramedic, and she was into tattoos, and so long story short, she had difficult intubation tattooed to her arm and tattooed upside down, so that if you were at the head of the bed getting ready to manage her airway, this was staring you in the face. At the University of Maryland, if we have a difficult extubation or anticipate one, we will have a huddle before that extubation. We'll have a surgeon in the room, and very often we'll have an airway tray open. Our patients that have tracheostomies or laryngectomies have a card at the head of the bed that gives details of that procedure, talks about what the airway was like before the tracheostomy was done, and who should be notified if there are issues. We also have a tracheostomy kit or a laryngectomy kit attached to this sign, and this sign and this kit follow the patient. If they go to CT or X-ray or something like that, it's attached to their IV pole and goes right with them. We also have some management algorithms that are also at the head of the bed, so that if you have your TIA at 2 o'clock in the morning and can't remember what to do, the management steps are staring you in the face. This is a little bit off topic, but I think it's very important to empower your nurses as far as airway skills. Let them know that if they're not getting the support they need, that they can ramp things up to anesthesiology or respiratory therapy without waiting for the house staff to give them that blessing. The analogy that I always tried to use for our nurses was if your house was on fire, you didn't try and put it out, and then when you couldn't, call the fire department. You called for help right away and then did what you could until the fire department got there. We've worked very hard to remind our staff that if someone is on room air, that a drop in saturation is a very early indicator of hypoxemia, but that if someone's on supplemental O2 and their PO2 is somewhere out here, that a drop in sat is a very late indicator of hypoxemia, and that if they have to increase the FiO2 to maintain the saturation, or the saturation is dropping, that's a high risk event. They need to get help on the way. Airway events have some randomness to them. So if you have 5 airway events in 1 year and 4 the next, are you doing a better job? Well, maybe, maybe not. If you have 3 1 year and 4 the next, are you doing a worse job? Maybe, maybe not. But I think you can look at trends overall. And I think with some of the things that we've done, we've seen an overall decrease in our airway events. So in summary, have you incorporated some airway management protocols into your electronic medical record or your anesthesia system? How do you work with staff outside the OR, make them aware of a difficult airway? And how have you educated them about airway issues? I hope today that I provided you with some low-lying fruit that you can grab, or at least take a serious look at, or worst case, maybe enjoy for lunch.